Chapter 2 is all about how we actually examine the external eye and cornea. I'm going to walk through the practical toolkit: history-taking pearls, external inspection, slit lamp fundamentals, illumination techniques, filters, stains, tear film evaluation, and adjunct devices like topography, pachymetry, and specular microscopy. By the end, you should know which technique to choose for a given clinical question, how to perform it correctly, and what pitfalls can mislead you at the slit lamp.
Fluorescein staining is a key clinical tool used to evaluate tear film stability, identify epithelial defects, and detect corneal perforation. Schirmer testing is employed to assess tear production dysfunction, particularly in dry eye conditions. Keratometry and Placido-based topography help detect irregular astigmatism, often indicated by distorted mires resulting from ocular surface abnormalities. More advanced imaging with topography and tomography offers detailed information on corneal power, elevation, and thickness, essential for diagnosis, surgical planning, and disease monitoring. Evaluating corneal biomechanics and thickness is important for assessing the risk of ectasia following refractive surgery and for interpreting IOP more accurately. Lastly, endothelial health and function can be assessed using pachymetry, specular microscopy, and confocal microscopy, providing insight into corneal integrity and guiding clinical decisions.
The external eye exam begins with assessing the patient's general appearance upon entry. Observations of demeanor, skin condition, and facial symmetry can reveal diagnostic clues, including rashes, pigmentation, proptosis, asymmetry, or orbital step-offs. The eyelids should be evaluated for lesions, inflammation, lash abnormalities, and malpositions such as ptosis or ectropion. Additionally, observe the blink pattern and frequency, which may provide insight into ocular surface health. If a foreign body or hemorrhage is suspected, eyelid eversion is essential. Corneal sensation is tested using a cotton wisp, ideally before any topical anesthetic or intraocular pressure measurement. In complex or subtle cases, a handheld esthesiometer may be used. Corneal innervation is provided by the nasociliary branch of cranial nerve V1, and findings should be recorded as normal, reduced, or absent.
Slit lamp examination utilizes various illumination techniques to evaluate different ocular structures. Direct illumination involves shining light directly onto the structure of interest. A common subtype is diffuse illumination, which uses a broad, low-intensity beam angled obliquely. This method is particularly useful for identifying surface irregularities, such as epithelial basement membrane dystrophy or iris lesions. Other key illumination modes include retroillumination, where light is reflected off deeper layers, like the retina or lens, to backlight anterior structures, helping detect subtle opacities or irregularities. Sclerotic scatter, in which oblique peripheral light enters the cornea and internally scatters to highlight stromal opacities. Specular reflection, a mirror-like technique used to assess smooth surfaces such as the corneal endothelium, achieved by setting the slit lamp and oculars at specific angles. Each technique offers unique advantages and is chosen based on the structure and pathology under examination. Focal illumination involves aligning the slit lamp light beam and microscope to concentrate on a specific ocular structure. A broad beam, approximately 3 millimeters wide, is well suited for examining eyelid lesions and corneal opacities, offering a wide illuminated field. In contrast, a slit beam, typically 1 millimeter or narrower, creates an optical section that allows detailed assessment of corneal architecture. This is particularly useful for evaluating corneal thinning, edema, stromal infiltrates, and endothelial abnormalities. Additionally, it helps detect cells and flare in the anterior chamber, offering vital clues in the diagnosis of intraocular inflammation.
Specular reflection is a direct illumination technique that relies on the mirror-like reflex of light off the smooth corneal surface, particularly the endothelium. It is especially useful for assessing endothelial cell density and morphology. Goutte and keratic precipitates appear as dark, non-reflective spots within the reflective mosaic. Optimal visualization requires high magnification, typically between 25x and 40x, to clearly resolve endothelial details.
Off-axis slit beam illumination enhances contrast and visibility of subtle corneal features by directing the beam slightly away from the visual axis, often toward the iris or red reflex. Proximal illumination involves decentering the light beam to accentuate small lesions, such as corneal foreign bodies, by exploiting differences in refractive index between normal and abnormal tissue. In sclerotic scatter, light is aimed at the limbus, where it travels internally and causes the cornea to glow. This technique is useful for identifying epithelial edema, stromal haze, or corneal verticillata. Retroillumination uses light reflected off the iris or fundus to backlight anterior structures. It is particularly helpful for detecting corneal opacities, neovascularization, iris defects, and lens changes.
Ocular surface staining is a key diagnostic tool used to evaluate tear film stability and epithelial integrity. Several dyes are employed for this purpose. Fluorescein stains areas of disrupted epithelial junctions, making it ideal for identifying defects in the corneal surface. In contrast, rose bengal and lissamine green stain devitalized or damaged epithelial cells, highlighting areas of ocular surface compromise. With fluorescein staining, positive staining appears where epithelial cells are missing or damaged, while negative staining suggests areas of elevation or abnormal tear distribution, such as an epithelial basement membrane dystrophy. The cobalt blue filter on the slit lamp enhances fluorescein visibility. Additional diagnostic tools include Schirmer testing to measure tear production and microscopy, which assesses the structure of the meibomian glands.
Fluorescein staining patterns provide valuable clues to the underlying ocular surface pathology. A diffuse staining pattern often indicates viral conjunctivitis or ocular trauma. Inferior staining is commonly seen in blepharoconjunctivitis or lagophthalmos, where incomplete eyelid closure affects the lower cornea. Interpalpebral staining, found between the open eyelids, suggests dry eye or exposure keratopathy. Superior staining is associated with conditions like superior limbic keratoconjunctivitis or trichiasis, where upper lid lashes irritate the corneal surface. 3 and 9 o'clock staining often points to contact lens-related issues, typically due to poor lens fit or inadequate tear exchange. Fornix or lower conjunctival staining can be linked to meibomian gland dysfunction. As a clinical tip, always perform flare assessment before applying fluorescein, as the dye can diffuse in the aqueous humor and mimic or obscure anterior chamber inflammation.
Now let's walk through some special fluorescein-based tests commonly used in evaluating the ocular surface and tear function. We'll start with tear breakup time, or TBUT. This measures tear film stability. After instilling fluorescein, the patient blinks once, then holds their eyes open. Under cobalt blue light, we time the interval to the first dry spot. If it's under 10 seconds, that's considered abnormal. Be sure to avoid using anesthetic fluorescein combo drops for this test. They can disrupt the tear film and skew the results. The dye disappearance test is another useful assessment. After placing fluorescein in the conjunctival fornix, we observe tear clearance over time. If the dye remains visible in the tear meniscus, that suggests impaired drainage, possibly a nasolacrimal obstruction. Then there's the Seidel test, used to detect aqueous leaks from corneal wounds or filtering blebs. Here, fluorescein is applied to the suspected site and viewed under cobalt blue light. A positive result is seen as clear fluid streaming through the orange dye, confirming a leak. Just remember, this test may be falsely negative in patients with hypotony. Several tests help quantify aqueous tear production and distinguish between types of tear deficiency. The basic secretion test is performed with topical anesthesia to eliminate reflex tearing, thereby measuring only basal tear secretion. A result of less than 3 millimeters in 5 minutes is consistent with aqueous tear deficiency. The Schirmer 1 test assesses total tearing, including both basal and reflex components, and is done without anesthesia. A measurement of less than 5 millimeters in 5 minutes also indicates aqueous tear deficiency. The Schirmer 2 test isolates reflex tearing by applying nasal stimulation, for example with a cotton-tipped applicator. A result of less than 15 millimeters in 2 minutes suggests reflex tear deficiency.
Quantitative tests help measure biochemical and structural changes in the tear film. Tear osmolarity above 308 milliosmoles per liter is indicative of aqueous tear deficiency, though it doesn't always correlate with symptoms. Lactoferrin levels reflect lacrimal gland function, with low levels supporting a diagnosis of dry eye. IgE testing is useful for distinguishing aqueous tear deficiency from allergic conjunctivitis. MMP9 is a marker of ocular surface inflammation. Levels above 40 nanograms per milliliter support evaporative dry eye and may also be elevated in Sjogren's syndrome and other autoimmune diseases. Structural assessments like interferometry and infrared mibography evaluate lipid layer thickness and meibomian gland dropout. On the qualitative side, meibomian gland dysfunction is a key contributor to evaporative dry eye. A slit lamp exam is essential to assess the eyelid margin and gland orifices. Non-invasive imaging techniques such as interferometry and mibography also help evaluate blink rate, tear breakup time, TBUT, and meibomian gland structure, offering both functional and anatomical insights.
Image A on the left is an infrared mibography of the upper eyelid, demonstrating normal meibomian gland architecture. The glands are long, straight, and show minimal or no tortuosity, which reflects healthy gland function and adequate lipid secretion. This structure supports a stable tear film and healthy ocular surface. Image B on the right shows a lower eyelid mibography with significant gland dropout. The glands appear shortened, truncated, and reduced in number, indicating severe atrophy and loss of structural integrity. This pattern is characteristic of MGD, a leading cause of evaporative dry eye. The reduction in lipid output compromises the tear film and contributes to ocular surface instability.
The shape and curvature of the cornea are fundamental to its refractive power, with the air-tear film interface serving as the eye's most significant refractive surface. Keratometry is used to measure corneal curvature and detect surface irregularities. Traditional manual keratometers, such as the Helmholtz and Djevall-Schotz types, operate under the assumption of a symmetrical cornea, but are limited to assessing only a central 4 mm zone. While keratometers are prone to misalignment, affected by patient gaze, and cannot detect spherical aberrations, they remain valuable for accurately measuring central corneal astigmatism and aiding in the early detection of keratoconus. That said, newer imaging technologies are increasingly replacing manual keratometers, especially in contact lens fitting and refractive surgery planning, where more comprehensive topographic and tomographic data are needed.
Keratoscopy differs from keratometry by providing qualitative data across a larger corneal area. It involves analyzing the reflected ring patterns, mires, projected onto the cornea. Closer or crowded mires indicate steeper corneal areas, while widely spaced mires suggest flatter regions. The short axis of the distorted ring reflects the steepest meridian, and the long axis corresponds to the flattest. Keratoscopy is particularly valuable for identifying paracentral and peripheral irregularities, which may be missed on central keratometry. It is especially useful in diagnosing conditions like keratoconus, pellucid marginal degeneration, and post-keratoplasty astigmatism. Corneal topography is a non-invasive imaging technique used to assess the shape and curvature of the anterior corneal surface and tear film. By analyzing thousands of data points, it generates a color-coded power map that provides detailed information about corneal curvature. This tool is essential in diagnosing corneal diseases, planning refractive surgery, and fitting contact lenses. Several types of power maps are used in corneal topography, each with specific clinical advantages. The axial map estimates central corneal power and offers a general overview of curvature, though it tends to underrepresent peripheral changes. In contrast, the tangential map is more sensitive to localized curvature variation and is particularly useful for detecting early or subtle peripheral irregularities. The mean curvature map uses a best-fit sphere model to represent the average curvature across the corneal surface, making it helpful for evaluating global shape and symmetry.
Corneal topography allows us to map the curvature and elevation of the anterior corneal surface with high precision. This is particularly helpful in detecting and monitoring corneal ectasia disorders like keratoconus at their earliest stages, often before visual symptoms arise. It also plays a key role in refractive surgery planning and follow-up. Before surgery, it helps us assess the pattern and magnitude of astigmatism. Afterward, it helps track outcomes and screen for postoperative ectasia. Beyond that, topography is useful in monitoring surface irregularities caused by conditions like pterygia, corneal scarring, and other degenerative changes. You'll often see several map types: axial curvature, mean power, and pachymetry, each providing complementary insights into corneal shape and thickness.
Corneal tomography is a non-invasive imaging technique that generates a three-dimensional image of the eye, allowing for detailed assessment of both the anterior and posterior corneal curvature, corneal thickness, and anterior chamber depth. It also provides structural imaging of the iris and lens, making it a powerful tool in comprehensive anterior segment evaluation. Its key clinical applications include detecting the risk of ectasia, such as in keratoconus, planning refractive surgeries, and monitoring ectatic disease progression over time. Compared to corneal topography, which only evaluates the anterior corneal surface, tomography provides data on both anterior and posterior surfaces, along with depth information, giving it a distinct advantage for early detection of subtle abnormalities. Common mapping techniques used in tomography include Scheimpflug imaging, for example, pentacam, scanning slit imaging, and anterior segment optical coherence tomography, or ASOCT.
Now let's dive deeper into the two main types of corneal tomography technologies. Scanning slit systems, like the orb scan, combine slit imaging with Placido-based topography. They're useful for comparing anterior and posterior elevation, especially in ectasia screening. But because the posterior surface is mathematically derived, these systems tend to overestimate posterior curvature, making them less ideal for precise excimer laser planning. In contrast, Scheimpflug-based systems, such as the pentacam, use rotating cameras and slit beam imaging to directly capture anterior and posterior surfaces. These provide accurate measurements of corneal curvature, thickness, anterior chamber depth, and pupil size. Some platforms even assess corneal opacity with densitometry. Overall, they offer more comprehensive and reliable data than scanning slit systems. The biomechanical properties of the cornea,
Particularly, its elasticity and viscosity play a crucial role in maintaining visual function and structural integrity. One key parameter is corneal hysteresis, which measures the pressure difference between inward and outward bending of the cornea during air puff applanation. This reflects the cornea's ability to absorb and dissipate energy, essentially its resistance to deformation. Low hysteresis values are associated with an increased risk of glaucoma and are also useful in evaluating the risk of ectasia prior to refractive surgery. Another important metric is the corneal resistance factor, which is calculated from hysteresis and corneal thickness. A lower CRF is typically seen in post-LASIK or PRK eyes, as well as in conditions like keratoconus and Fuchs endothelial dystrophy. While CRF is useful in interpreting IOP readings, it is less reliable than hysteresis for screening ectatic disease.
Next is specular microscopy, which is used to assess the corneal endothelium. This can be done with contact, non-contact, or confocal microscopy. We focus on two main metrics, density and the coefficient of variation, or CV. A normal adult has about 2,400 cells per square millimeter, with a lower limit around 1,500. If density drops below 1,000, there's a higher risk of corneal decompensation. Cell size ranges from 150 to 350 microns squared, and gouttes, seen as dark areas on the image, indicate endothelial dysfunction. The coefficient of variation reflects how variable the cell sizes are. A CV under 0.3 is normal. Anything over 0.4 suggests polymegathism, as seen with chronic contact lens wear. A high CV also means higher risk of corneal edema after surgery.
Endothelial health can also be assessed by cell shape. Normally, nearly all endothelial cells are hexagonal. A drop in that percentage, called hexagonality, reflects poor cell health. Pleomorphism refers to variability in cell shape. If fewer than 50% of cells are hexagonal, that suggests high pleomorphism and a stressed endothelium. This increases the risk of decompensation after surgery. In summary, these metrics help assess surgical risk and monitor corneal disease progression.
Corneal pachymetry measures corneal thickness and plays a crucial role in assessing endothelial function and accurately interpreting IOP. A normal central corneal thickness ranges between 540 and 550 microns. This measurement is especially important because thicker corneas can lead to overestimated IOP readings, while thinner corneas may result in underestimated IOP and are also associated with an increased risk of glaucoma. In cases of corneal edema, thickness typically exceeds 700 microns, often impairing vision. Epithelial microcystic edema and bullae are especially detrimental to visual clarity. A 10% increase in corneal thickness can produce Descemet's membrane folds, while at 700 microns, epithelial edema becomes likely and may cause significant vision loss. A helpful clinical pearl is that persistent morning thickening of the cornea may indicate endothelial dysfunction, as the lack of overnight evaporation leads to temporary corneal swelling and blurred vision upon waking.
Confocal microscopy is a non-invasive, high-resolution imaging technique that provides cellular-level views of the corneal layers. It works by using a laser or light source in conjunction with a camera focused in the same optical plane, allowing for sharply focused cross-sectional images of corneal microstructure. Clinically, confocal microscopy is valuable in the diagnosis of infectious keratitis, including acanthamoeba, fungal, and herpetic infections, where conventional techniques may be inconclusive. It also plays a critical role in evaluating the corneal nerve plexus, particularly in conditions like neurotrophic keratitis or neuropathic ocular pain following refractive surgery. In addition, it serves as an alternative to specular microscopy for assessing corneal endothelial cells and aids in identifying and monitoring various corneal dystrophies. Anterior segment optical coherence tomography, or ASOCT, is a non-invasive, high-resolution imaging modality used to obtain detailed two-dimensional cross-sectional images of the cornea, anterior chamber, and iris. It comes in several forms, including time domain, or TDOCT, frequency domain, or FDOCT, which includes spectral domain, or SDOCT, and swept source OCT. These systems can be utilized in office or intraoperatively, particularly during procedures like keratoplasty or membrane peeling. Clinically, ASOCT is indispensable for assessing anterior chamber depth and angle, corneal and epithelial thickness, and graft integrity after surgery. It plays a central role in preoperative planning for Fuchs endothelial dystrophy and postoperative evaluation of graft shape and attachment. ASOCT is also valuable in LASIK by allowing visualization of the flap and stromal bed, guiding enhancement decisions. Additionally, it provides accurate measurements of true corneal power for IOL calculations in post-refractive surgery eyes and helps identify corneal ectasia by detecting epithelial thinning over the cone apex. Lastly, it is a sensitive tool for detecting ocular surface squamous neoplasia.
Ultrasound biomicroscopy, or UBM, utilizes high-frequency ultrasound to provide high-resolution in vivo cross-sectional imaging of the anterior segment, including the cornea, iris, ciliary body, and lens capsule. Unlike ASOCT, UBM can penetrate opaque ocular media, such as dense corneal opacities or total hyphemas, offering a diagnostic edge in certain challenging cases. It is particularly effective at visualizing the scleral spur, a key landmark in angle anatomy which makes it invaluable for angle assessment. UBM is clinically used to evaluate a wide range of anterior segment disorders. It is excellent for diagnosing descent membrane pathologies like ruptures or detachments, as well as a host of angle abnormalities, including angle recession, cyclodialysis clefts, plateau iris, narrow angles, and malignant glaucoma. Additionally, UBM plays a critical role in the detection and evaluation of ciliary body lesions, such as cysts or tumors, and is also used to assess phakic intraocular lens positioning and haptic configuration. It can aid in diagnosing syndromes like pigment dispersion and Peters anomaly, further underscoring its utility in both routine and complex anterior segment evaluations.
Thank you for taking the time to go through this lecture. We've covered a lot of foundational material that's critical for understanding the cornea and external disease. To help reinforce your learning, we've included review questions at the end. Take a few moments to work through them. They'll help solidify the key concepts and highlight areas worth revisiting.